Welcome to the Society of Critical Care's Medicine Sepsis Redefined webcast. My name is Craig Coopersmith, and I'm the immediate past president of the Society of Critical Care Medicine. It is now my pleasure to introduce our presenters today. Our first presenter is Clifford S. Deutschman, MD, Vice Chair of Research, Department of Pediatrics at the Stephen and Alexandra Cohen Children's Medical Center in New Hyde Park, New York. Dr. Deutschman also serves as Professor of Pediatrics and Molecular Medicine at Hofstra Northwell School of Medicine in Hempstead, New York. Our second presenter is Mitchell M. Levy, MD, Chief of the Division of Critical Care, Pulmonary and Sleep Medicine, and Professor of Medicine at the Warren Alpert Medical School of Brown University. Dr. Levy also serves as Medical Director of the Medical Intensive Care Unit at Rhode Island Hospital in Providence, Rhode Island. Drs. Deutschman and Levy are both past presidents of the Society of Critical Care Medicine. This webcast today will include approximately 50 minutes of content followed by a question and answer session. At the end of today's webcast, attendees will be able to understand Sepsis 3 and related clinical assessment tools, recognize the rationale behind the new definitions for sepsis and septic shock, understand the relationship in the new sepsis definitions to bedside screening and treatment of patients. CE, CME credits are not available for today's webcast. This webcast is supported by our friends in the Gordon and Betty Moore Foundation. You are invited to ask questions for our presenters throughout the webcast. You may do so by typing your questions into the question box in your GoToWebinar panel. Questions will be addressed after the presentation. This webcast will be available at www.fccm.org/sepsis-redefined and on FCCM's YouTube channel within 3 business days. We encourage you to post on Facebook if you like this webcast and continue the conversation on Twitter using #SepsisRedefined. If you would like more information about the new sepsis definitions, visit the links below. FCCM's website, http://www.fccm.org/sepsis-redefined, or our colleagues in the European Society of Intensive Care Medicine, or the Surviving Sepsis Campaign, www.survivingsepsis.org. The slides from today's presentation will soon be available on the FCCM website at www.fccm.org/sepsis-redefined. Now I will turn over the program to Dr. Deutschman. Cliff?
Thank you, Craig, and thank you, ladies and gentlemen, for listening in. Can someone get me the next slide, please? Thank you. What I'm going to talk to you about today is the several topics regarding the new definitions of both sepsis and septic shock. The first question we'll address is, why do we need a new definition? The first reason that a new definition is so important is that there were real issues with the previous definitions formulated by consensus conference convened in 1991 and 2001. These definitions were based upon the Systemic Inflammatory Response Syndrome, SIRS. They introduced a new term, severe sepsis, which has proven to be problematic. And as a result of different assessment criteria, the net effect is different results. We'll talk about each of these in a little more depth. Regarding SIRS sensitivity, 2 recent papers have highlighted the potential problems. The first is a paper published out of Australia and New Zealand. These individuals, the investigators, looked at a series of patients admitted to the intensive care units in various hospitals throughout that region and discovered that quite a number of them, while critically ill and meeting other criteria for sepsis, did not meet the SIRS criteria. That is, they did not have the presence of 2 or more of the SIRS criteria. Indeed, 1 in 8 of these patients would not have been deemed to have sepsis. A second study was conducted at the University of Chicago looking at floor patients. In this group, about half of the floor patients who were not critically ill still met criteria for both suspected infection and 2 or more SIRS criteria. So again, these patients might have been deemed septic when they were not, thus the need to move beyond the SIRS criteria. So indeed, SIRS is an appropriate response to infection or any other stimulus that activates inflammation, but it may not be appropriate to identify patients with sepsis. To some extent, the notion of sepsis and severe sepsis is confusing. Severe sepsis is defined as sepsis that is suspected infection plus 2 or more SIRS criteria and the presence of organ dysfunction. However, most people say sepsis when what they mean is severe sepsis. What the 2 initial task forces called sepsis is what most people would call infection. This interesting study by Iaski and others highlights some of the difficulties with application of different criteria. In these studies, they looked at the incidence and the mortality from sepsis over the course of a 6-year period. They defined sepsis using 4 separate criteria, looking at large databases and identifying patients included in those databases. What you can see is that while indeed the incidence of sepsis and the mortality from sepsis both increased, basically depending on the method used to identify those patients, there was wide discrepancy. The incidence varied anywhere between slightly under 1 million to in excess of 3 million, the mortality between 250,000 and 375,000. Mortality from septic shock also differs across geographic lines. In Australia, and similarly in the United States, the mortality from septic shock is low, somewhere in the neighborhood of 20 to 22%. However, in both Germany and the Netherlands, which have equally well-developed healthcare systems, the mortality of the same disorder is listed in excess of 60%. Clearly, this is a function of something other than the patient population and the care being delivered, and primarily reflects the availability of intensive care unit beds, many of which get filled with patients who are less ill in the United States and in Australia as compared to some European countries. We have an increased understanding of sepsis pathobiology. It's more than just unimpeded inflammation. We now understand that there's a significant role for immunosuppression and indeed anergy. There is a contribution from mechanisms that don't involve the immune system at all. It's possible that organ dysfunction, at least initially, may represent an adaptive response to some underlying defect. And the entire nature of septic shock as an independent entity is undergoing reappraisal. As a result of these issues, the Society of Critical Care Medicine and the European Society of Intensive Care Medicine several years ago convened a task force to redefine sepsis, to re-examine what was in the literature and to update, refine, and redefine as needed. These are the members of the task force, which I had the privilege of co-chairing with Mervyn Singer from University College London, and which I should point out included both our moderator and Dr. Levy, my fellow panelists. As a result, this particular paper was generated and published in the February 23rd edition of JAMA. Primary authors as listed, all members of the task force. So let's talk about what these new definitions are. But to start, we have to talk about what actually we mean when we say definition. According to the Merriam-Webster English Language Dictionary, a definition is a statement expressing the essential nature of something, or to put it more generically, a statement that describes what something is. Now, I think it's safe to say that our understanding of the pathobiology of sepsis is at best incomplete, and we would be very hard-pressed to say that we understand the essential nature of sepsis, what sepsis is. That left us with an interesting dilemma, which I'll come back to in a minute. Based on our understanding of the pathophysiology at this point, we decided that sepsis should best be defined. That is, the best way to explain its essential nature is to say that it is life-threatening organ dysfunction caused by a dysregulated host response to infection. Septic shock proved to be a little more problematic. As I mentioned, it's undergoing reappraisal. One could question whether or not septic shock is simply sepsis where the dysfunctional organ is the cardiovascular system. The task force's opinion on that was no, septic shock also involves abnormalities on the cellular and even on the biochemical and metabolic levels. So what distinguishes septic shock from sepsis? Is it the treatment? No, because the management is clearly the same for both. Is it the pathobiology? Well, maybe, but we don't know enough about the pathobiology at this time to say that with any certainty. What is tangibly different, however, between septic shock and sepsis is the mortality. Simply put, septic shock is really, really, really bad sepsis where the mortality is particularly high. As such, the definition of septic shock is a subset of sepsis in which profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than with sepsis alone. The advantages of these new definitions are that they incorporate the most up-to-date thinking on sepsis pathobiology, and they provide the closest approximation to describing what sepsis is. The concerns, of course, is that they are of limited practical utility because they contain elements such as organ dysfunction or dysregulated host response that simply can't be defined or identified clinically. This led us to approach the problem of clinical recognition, and this started with an examination that ultimately led to a new term, qSOFA. Let's go into that in a little depth here. The paper, primary author Chris Seymour from the University of Pittsburgh is indicated here. When we say that sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection, we start out by looking in a large clinical data set at those patients who have suspected infection and attempt to identify as a surrogate for life-threatening organ dysfunction those patients who are really sick. In diagrammatic form, if this circle represents all the patients that we see, somewhere within this circle is a subset, a smaller circle of patients with infection, and within that group is a subset who have sepsis, that is, who indeed have dysregulated host response that's life-threatening and organ dysfunction. However, we need some way to identify those patients that doesn't rely on organ dysfunction or dysregulated host response. And therefore, we substitute for sepsis, really sick. The question then becomes, how does one identify really sick patients? The challenges involve what data sources to use, how one might identify infection, what are the clinical criteria, those things which we can recognize at the bedside or measure using the laboratory or x-rays that need to be looked at, and how do we identify patients who are really sick? Let's take these one at a time. The data source that was chosen initially for the derivation of our new sepsis clinical criteria, things that we can use to identify potentially septic patients, was an electronic health record from the University of Pittsburgh Medical Center. 1.3 million records were identified. Once we had results from those 1.3 million, the results were verified in 4 additional data sets comprising almost 6 million additional records from the Kaiser Permanente, Northern California System of Hospitals, the United States Veterans Administration, the alerts database from our colleagues in Germany, and the Kings County Seattle Emergency Medical System. We identified infection as occurring, as being suspected when cultures were sent and antibiotics were started for the first time. Looking in the 1.3 million records from the UPMC, Seymour et al. Identified 148,000 patients with suspected infection. Again, this was validated in the 4 data sets mentioned, and the result was another 700,000 patients with suspected infection. What clinical criteria might we study? Well, clearly, previous definitions were based on the SIRS criteria: temperature, heart rate, respiratory rate, and white blood cell count. Another frequently used approach to clinical criteria to identify sepsis is the SOFA score, the Sequential Organ Failure Assessment score. This consists of a number of measures, each of which receives a point. There are up to 24 points. There are 13 different variables, clinical labs, and therapeutic data available. Another potential tool would be the Logistic Organ Dysfunction score, or LODES, again 0 to 22 points, with a lot of similarities to the SOFA score. How do we identify who is really sick? We're looking for possible proxies for really sick. We could do this on the basis of decisions by clinical review committees. We could look at death in the hospital. We can look at prolonged stay in the ICU, discharge diagnosis of sepsis, or positive microbiological data. The approach that was chosen was a combination, a composite of death in the hospital and a prolonged stay in the ICU. One could then look at the distribution of these existing criteria both in the ICU itself, as shown in the upper set of panels, and in the outside the ICU. What you see when you look at the SIRS criteria is that 2 or more are identified in the great majority of patients who were admitted to the ICU. SOFA score of greater than 2 was identified again in a great number of patients, the majority admitted to the ICU. And the LODE score also identified, of greater than 3, identified a great majority of the patients admitted to the ICU. However, when we get outside the ICU, what you discover is that the data among infected, potentially infected patients is skewed to the lower end. That is, 2 or less criteria are identified, 1 or less criteria are identified in the majority of patients using the SIRS criteria, lower levels on both the SIRS and the LOD score. To develop new criteria, one has to look at the timeliness and the ease of use. To do this, Chris Seymour and colleagues took 21 variables, all of which were originally outlined in the infamous Table 1 from the Sepsis 2 paper published in 2003. Multivariate logistic regression for in-hospital mortality was used. The derivation data set, as we said, was the UPMC, Emergency Electronic Health Record, and additional electronic health record data were used to validate their findings. In the process of looking at all these variables and potential combinations of variables, Seymour et al. Were able to identify a new set of parameters which they called qSOFA for qSOFA. This consisted of a respiratory rate of greater than 22 breaths per minute, a change in mentation, an alteration in mentation, and a systolic blood pressure of less than 100 millimeters of mercury. In assessing these criteria and comparing SIRS, SOFA, LODES, and qSOFA, one can see that in the ICU there's a superiority to SOFA and LODES. However, outside the ICU, shown in the right panel, qSOFA is similar to the complex scores and seems to be better, have greater prediction validity for mortality, or prolonged ICU stay than the use of the SIRS criteria alone. Serum lactate has been touted as an excellent biomarker for sepsis, and indeed it does have predictive validity over the course of time. However, with the initial assessment that was used to construct qSOFA, adding lactate did not improve predictive validity. One can see here in this graph that the baseline risk, which is based on underlying disease, is 1. It is enhanced by the use of qSOFA, and adding a lactate of greater than 2 did not appreciably improve predictive validity. So the new definition of sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection, and among patients with suspected infection, a SOFA score of 2 or more, or a change of greater than 2, which we call delta SOFA, or in the emergency room or on the wards, a qSOFA score with 2 of 3 points constitute clinical criteria that will identify a great majority of the patients who are highly likely to have sepsis. How about identifying clinical criteria for patients who we believe have septic shock? This is a little more problematic. The problem was approached by Manu Shankar-Hari from St. George's Hospital in London, from Guy's and St. Thomas's Hospital in London, and colleagues, and this is the paper that appeared in the same issue of JAMA. The task force itself identified a definition of septic shock that we've spoken about, that is, a subset of sepsis in which profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than with sepsis alone. This was arrived at by the use of a Delphi method among members of the task force, and as with sepsis, it contains elements that are difficult to identify clinically. What subset of sepsis do we need to be looking at? Well, among patients who have sepsis, so we're starting with patients who have sepsis, a potential difference lies in the mortality, in this case hospital mortality. And those with hospital mortality in excess of that seen in the sepsis group alone were served as a surrogate. That is, these are patients who are not just sick, but are really, really, really sick and have a 50-50 chance of dying. To look at it using the diagrams we used before, if septic shock is a subset of sepsis characterized by profound circulatory, cellular, and metabolic abnormality, measures that cannot be readily identified clinically, the proxy that can be used for really, really, really sick is hospital mortality. This was originally tested in a derivation cohort, this time derived from the Surviving Sepsis Campaign database. This consisted of a little over 28,000 patients who were entered into the database because they met previous criteria for severe sepsis or septic shock. Validation of the findings was in the data set from Pittsburgh and the data set from Kaiser Permanente. Criteria to be tested were once again identified by the task force using a modified Delphi process, and it was felt that after fluids had been given, continued hypotension, vasopressor dependence, and an elevation in lactate were reasonable surrogates for really, really, really sick and might identify those patients who were highly likely to have mortality of a very high level. Now, looking at those 3 variables, you can see that there's 6 possible groups with either 1, 2, or 3 of those variables present. The data sets were examined to find patients who fit into each of these groups. You can see that the percentages in 2 of these groups were very low, that were too few patients to truly assess them, so they could be eliminated. When we eliminate that group, what we discover among the 4 groups that remain is that group 1, which had both hypotension after fluid resuscitation and ongoing need for vasopressor support and a lactate in excess of 2, had a mortality that was significantly higher statistically than the mortality in the other three groups. So, if the new septic shock definition is a subset of sepsis in which profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than sepsis alone, the clinical criteria used to identify those patients are those who, despite adequate fluid resuscitation, have an ongoing need for vasopressors to maintain their mean blood pressure greater than 65 millimeters of mercury, and also have a lactate in excess of 2 millimolars per liter. To summarize, sepsis is life-threatening organ dysfunction caused by a dysregulated host response to infection. Septic shock is a subset of sepsis in which profound circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than with sepsis alone. Outside the ICU, patients with suspected or presumed infection who are highly likely to have a poor outcome can be clinically identified using qSOFA, a systolic blood pressure of less than 100 millimeters of mercury, a respiratory rate of greater than 22 breaths per minute, and an alteration in mental status. These are the patients who are most likely to be septic. In the ICU itself, however, these abnormalities may be changed because we control respiratory rate, we control the blood pressure using medications, and we tend to sedate patients so the mental status may not reflect the true condition. However, these patients with suspected or presumed infection who are likely to have poor outcomes in the ICU, when in the ICU, can be clinically identified with 2 or more SOFA points. And finally, patients with septic shock can be clinically identified if, despite adequate fluid resuscitation, they require vasopressors to maintain a mean arterial blood pressure of greater or equal to or greater than 65 millimeters of mercury, and a serum lactate level, have a serum lactate level that is greater than 2 millimoles per liter. Thank you very much. On that note, I'll turn things over to Dr. Levy.
Thanks, Cliff, and I appreciate being here. What I'd like to do in the last maybe 10 or 15 minutes is talk about alternative sepsis criteria. And much of what I'm going to talk about is from this manuscript that we published at the same time in Critical Care Medicine as the manuscripts that came out that Cliff just reviewed came out in JAMA. What I'm presenting is a result of a CDC task force that both of my colleagues on this call were also on. And I think to create the context for this, basically we looked at, or I should say acknowledged, that regardless of what we think about the new definitions, and I think that there's no question that those of us on the task force believe that we have advanced the field, as Cliff has outlined, in a more clear definition of sepsis and introduced something, qSOFA, that perhaps will turn out to be a valid criteria for identifying patients at higher risk of mortality. Having said that, there are ultimately going to be currently more than one definition of sepsis. And you see on this slide here, right now we have the definitions that we just introduced with the Third International Consensus definition. As I'm going to talk about at the end of this, CDC is going to introduce a national surveillance definition, and as we know, CMS is using the Step 1 initiative, which essentially utilizes the old definitions, which really can make grown people cry, given that we're under so much pressure to collect data and identify sepsis properly. To have all these definitions is very frustrating for many of us. However, I think the truth is, currently there simply is no perfect method to unambiguously characterize patients as having sepsis or not. We have, for over 20 years now, looked for the magic biomarker that will allow us to be more objective in diagnosing sepsis, akin to using troponins or echoes or an EKG to diagnose an MI. And the truth is, we've been unable to find a single biomarker, or any test for that matter, that conclusively diagnoses whether someone is septic or not. So we're left with 3 different iterations of definitions for sepsis in an attempt to try to clarify it for practicing clinicians. In addition, there are a lot of different initiatives for sepsis, and I'm going to go over those in a moment, and each of those different each of those initiatives has essentially different goals. And so what I want to do is outline for you what I think are 4 broad purposes for sepsis criteria, and ultimately that really enable 4 different definitions, if you will, of sepsis. One for clinical care, one for research, both basic and clinical research, one for surveillance, and then another one that could be used for quality improvement and audit. And so that's what we're going to go through this year. This here first is a slide looking at clinical care, and on each of these slides that follow, you're going to see 4 columns, which are the objective of each of these initiatives or criteria, the example of them, the criteria used for the definition, and some comments about it. The first one is for clinical care, for identifying a patient every day at the bedside in sepsis, just for either coding or to begin to treat them properly in early diagnosis and management, and to inform clinical care. The example was just presented by Dr. Deutschman, which is the 3rd International Consensus Definition. The criteria, he's just spent a fair amount of time and in a very articulate manner identified the clinical criteria for identifying patients with sepsis and septic shock, and I'm not going to go over that now. To look at, for research, we're going to look at research both for clinical research and basic science research. So for clinical research, and many of you on this call may be involved in and participating in a multi-center clinical trial for a new agent in sepsis. So the objective in this instance for a potential definition would be to guide the conduct of clinical research in sepsis. An example, and I could have chosen many different examples for the purposes of this manuscript, we chose the enrollment criteria for the ACCESS trial, which was eritorin, a TLR4 initiative, inhibitor. And among patients, the criteria here were the old criteria with which we're very familiar, and that is 3 or more SIRS criteria, evidence of 1 major organ dysfunction, and a high risk of death as identified by an Apache 2 score. Now, each clinical trial has to a certain extent different entry criteria, but all of them more or the same, have been up until now very common, very similar in that they use some version of the SIRS criteria, definitions that are fairly traditional of organ dysfunction, and in some cases, hopefully identifying patients at high risk of death. I think a couple of points here. The current clinical trials will continue to use these criteria. So it's important, if we're involved in these trials, for all of us to know that we shouldn't anticipate these entry criteria changing until the end of the study and a new study is planned, because it would be obviously inappropriate and problematic for any trial to change entry criteria in midstream. And so therefore, the criteria that are currently being used for clinical research will stay the same despite our recent introduction of the new definitions. Basic science has an entirely different, whoops, if I can get that back. Basic science has an entirely different set of objectives and criteria. Here, we're looking in basically animal models to study fundamental principles in pathophysiology and pathobiology of sepsis. Examples here for basic science research would be the murine sepsis score after fecal-induced peritonitis with cecal ligation and puncture. And the criteria in these basic animal models is a score, and you see here some of the criteria for the score. And basically, often these criteria may be species specific. Over time, animal models are beginning to change for various reasons, not the least of which is questioning whether our current understanding of animal models altogether apply well into the human model, which may account at least in part for the large amount of negative clinical trials that we've seen over the last 20 years. But my point here is that, again, we see in the instance of basic science research, we'll use different clinical criteria for a definition of sepsis in an animal model than we may use in the one that you just heard Dr. Deutschman present. Next is surveillance and epidemiology. So the CDC now has jumped with both feet into the sepsis arena nationally, and being mandated so by Congress and to a certain extent public pressure. Their objective, as they're discussing more and more, what they'd like to do with sepsis is to essentially track local and national burden, essentially incidence and outcomes of sepsis across hospitals over time in the United States. That's essentially not dependent on coding, and we don't have time to talk about it here. And Cliff actually showed you some of the slides, which depending on the coding approach you use will give you a completely different numbers in the United States for the epidemiology of sepsis, at that time sepsis, severe sepsis, and septic shock. And so CDC is making an attempt to develop a surveillance definition that will not be dependent on coding and perhaps allow for a better snapshot of the incidence of sepsis across the United States. And you see here the criteria that's being discussed. Now these aren't, CDC every time I've presented this asked me to remind myself and all of us that these are criteria under investigation. They are not settled upon, they're not about to be introduced, but these are what are under consideration. And here they are amongst patients with infections greater than one of the following: either vasopressor use, more than 2 days of mechanical ventilation, or a rise in serum creatinine of greater than 0.5. And the reason that these were chosen is an attempt to avoid data elements that are not readily available in the electronic health record, which makes the widespread determination and collection of data about this type of surveillance definition relatively easy. I think CDC is very interested in avoiding adding to the onerous nature of data collection that CMS has introduced with Step 1 for national reporting in sepsis, and while at the same time capturing a different snapshot of sepsis patients than the CMS's initiative is choosing. And so what I'm trying to do here is show all of us why, although we're maddened by all of these different definitions, there are different objectives that in many ways require different entry criteria and clinical criteria for reporting. And this is a good example here of how a national surveillance definition that allows for automated data reporting and reduces the data burden that's for the CDC is going to have a very different look than either the definition that Cliff just introduced to you and that you've seen in JAMA, or ones that I've been talking about up until now. And finally, QI and audit. So the QI and audit, which is to inform quality improvement initiatives and audit performance across hospitals. The examples of that, obviously, the Surviving Sepsis Campaign in the past, but Surviving Sepsis Campaign was limited to only 220 hospitals globally. The better example now is the one we're all in the midst of in the United States, which is the CMS measure, which is Step 1. And in the CMS measure, we're asked to nationally report into inpatient quality reporting compliance with the performance measures that were developed by the Surviving Sepsis Campaign into a national database collected by CMS. Their identification of these patients is through ICD-10 coding identified locally at institutions that then leads to a manual chart review that's carefully specified in the CMS regulations to looks back again at the previous definition, looking at SIRS criteria, organ dysfunction according to the previous definition criteria, and terminology that's consistent with the previous definitions of sepsis, severe sepsis, and septic shock. There's no question that this identifies a sicker population than any of the other definitions we've seen so far. I will tell you up front that CMS has a letter that's about to go and into JAMA and be published sometime in the next month or so, in which they will announce that they will not immediately adopt our new third iteration of sepsis definitions. But in order to continue along the path of the Step 1 initiative, they will continue to use the old definitions. This next slide is from the manuscript that I've already alluded to earlier, and that these previous slides are from. And this is basically a case identification that is from a group of hospitals in Pennsylvania that Chris Seymour pulled with Derek Angus. And it just shows you the differences in outcomes and incidence using the definitions I just described, all 5 of them. And what I would draw your attention to is the last 2 red bars, the ICU admission number. You can see here the difference in patients who were admitted to the ICU across all these 4 definitions. The lowest rate being in the clinical criteria we just introduced in JAMA in February that Cliff just reviewed, and the highest rate being in the old definition criteria that are being used by CMS. And that's also true for mortality, as you can see in the final bar. And these are the definitions that are in existence being applied to a live database from the state of Pennsylvania. And you see here the mortality rate being very varied, ranging from 8.9% according to the current definitions, the 3rd iteration that we just talked about, all the way up to the 24% by using the CMS criteria, which are essentially the 2nd definition conference criteria. So good examples that hopefully show you that for the foreseeable future, we are likely to have to live with these multiple definitions. And in part, trying to explain why we might have to do that is showing that different initiatives really are requiring, for at least the current time, these different definitions with different clinical criteria. Although they're maddening to clinicians, they serve different purposes. And hopefully, over time, as more data come out, further validating the use of qSOFA and confirming that it is a good screening criteria for patients who are likely to do poorly with sepsis and not miss a significant population, that over time these different definitions will be harmonized into a single definition. But I think it is safe to say that for the foreseeable future, we are going to see different definitions used for the reasons I just identified. And I'm happy to answer questions about this, and I realize how difficult it makes us at the bedside as bedside clinicians, especially in terms of reporting, to see different definitions that require different efforts and different data collection. So with that, I'll say thank you and turn it back over to Craig.
Thank you very much, Mitchell. We only have a few questions so far. We have time for more, so if anybody listening wants to send extra questions, we'll certainly have time to answer them. I'm going to start with a question that I'm going to ask both of our panelists to answer because it's the billion-dollar question. What should we be doing clinically? Should we start using the new definition, the old definition, or both? I'll start with you, Cliff, and I'm going to have Mitchell answer right afterwards.
Well, first of all, obviously I'm biased. All 3 of us put a great deal of effort into these new definitions, and so obviously we have a vested interest in their use. That said, I think the data demonstrate that they have better predictive validity than prior approaches. So again, my sense is that what we ought to be using are the new definitions, the use of SOFA greater than equal to, or qSOFA, or for septic shock, pressure-dependent hypotension and an elevated lactate. That said, for the clinicians on the call, you're going to be, especially those in the United States, you're going to be held to the fire by CMS. If you want to get paid, you're going to be asked to use SEP1. I think Mitchell's point that we're just going to have to get used to using more than one definition until some impetus for harmonization comes along is unfortunately correct. It's maddening. It's annoying. I wish it weren't so, but I'm afraid it's the reality of what we deal with right now.
Mitchell, I'd like to hear your take on that as well.
And Craig, was the question the new definitions, or was it specifically qSOFA?
No, it was the new definitions. The question was, should we use the new definitions, the old definitions, or both?
Yeah, so this is a tough question. We knew going into this, and I would echo what Cliff said, that we believe these new definitions are an advancement, but we knew going into this that this was coming out at a rather inopportune moment in history, and that is right during the SEP1 initiative. So if the SEP1 initiative did not exist, I would say we should be using the new definitions. The problem is, right now, for ICD-10 coding, it is extremely important for both providers and hospitals that the coding is done as severe sepsis, not as sepsis, because otherwise you couldn't really bill a critical care code for a patient with simple sepsis, And so it gets very tricky, and unfortunately I've been saying out loud that we're actually telling clinicians to write sepsis because I believe that we already say sepsis, even though we meant for a long time severe sepsis. We're telling people to say or write sepsis, but code severe sepsis. And when I say this to coders, and I've talked to a couple of coding organizations already since the definitions come out, they remind me that you cannot do that. That if what you write in the chart is sepsis, 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 they simply cannot code severe sepsis. So, and then on top of that, you have a situation with SEP1 where we will be held to the old clinical criteria of SIRS. And so, in a way, we are really stuck in the middle. So my answer, this feels like I'm dancing on the head of a pin, my answer is that for the purposes of billing, we actually still need to use the old definitions, because otherwise we will not be eligible either as providers or hospitals for the proper reimbursement. So I think what I'm saying is, at least in our notes, we need to use the old definitions. What definitely does not work is to look at just qSOFA, and if you do not see criteria consistent with qSOFA, basically say the patient is not septic. We cannot make that change now. It is too soon to make that change.
If I may add, I fell into my own trap here too. The definitions are the definitions. The closest thing that we have to saying what sepsis is life-threatening organ dysfunction that caused by a dysregulated host response to infection. What we're talking about here is which clinical criteria to use. And that adds a further layer of confusion because, as we've seen both of us doing right here today, people use clinical criteria and definition interchangeably, and they really don't mean the same thing.
Thank you. And to everybody listening out there, thank you. From the time that I asked that question till now, the number of questions have quadrupled, so thank you. I'm going to follow up to what Mitchell said. I'm going to give him the next question. Since we just started talking about coding and billing, when do you see billing or ICD-10 implementation catching up with the new definitions of sepsis? I feel like my colleagues are hesitant to switch because of billing purposes.
Yeah, I think that's right. And unfortunately, I don't think any of us know. I honestly do not think we're going to see a change in the coding until ICD-11, so that's not happening anytime soon. So the reality is, I don't even think we can count on this coding being responsive to us. Remember, it took a long time. It was, I believe, a 6-year effort to get the sepsis, severe sepsis, and sepsis ICD-9 codes into ICD-9. And so the likelihood of us achieving a change in those coding within the next 2 to 4 years is very low. And unfortunately, that means, for now, you must bill severe sepsis or septic shock to get the proper reimbursement for your patients and a hospital.
The next question is going to go to Cliff, because Cliff, at one time was an adult person, is now a pediatrician, and 3 separate people have asked, is qSOFA or the new definitions appropriate for pediatric patients?
A great question, and let me first start with the disclaimer that I'm a pediatrician on honoris causa. It's purely honorary. I happen to work in a pediatrics department as the director of research. I remain someone completely trained in the adult realm. That said, the definition is the definition. It's the closest thing that we have to date to a statement as to the true nature of sepsis. The true nature should apply, if we're talking about the same disorder, to both adults and children. Now, if what we think we're talking about is a completely different disorder with completely different or significantly different underlying pathobiology, that's a different story altogether. The clinical criteria, qSOFA, has been tested and validated retrospectively in adult populations. It has not been tested yet in pediatrics, and it may well not work in pediatrics. Given the difficulties that Mitchell has pointed out very clearly with coding and billing in the adult setting, it would certainly be very problematic to attempt to extend this to a pediatric population in which no attempt has been made yet to validate it. Now, I will also add that there are efforts underway at this time to begin to organize examination of qSOFA in the pediatric population, and perhaps even to repeat the process in patients between the age of 2 and 15, the process that Seymour and Shankar Hari underwent to come up with clinical criteria. It will take some time for those processes to weave their way towards completion. Certainly when we started the whole Sepsis 3 effort, it's been 5 or 6 years since we first started discussing it, and it took us 2 years of meetings with the task force as a whole to actually get to the point where the papers were ready to be submitted. So these new clinical criteria have not been tested. They have no predictive validity at all in children, and you apply them to children with your own at your own risk with discretion. Hopefully we'll have an answer to that question that's data-driven sometime in the near future.
I'm going to follow up on that because you talked about qSOFA in adults and how it was a retrospective thing, and somebody writes, I was under the impression that the qSOFA score should not be used until it has been prospectively validated. Could you touch on that one, Cliff?
Well, again, I think that prospective validation is important. I think it definitely needs to be done. I'd be very surprised if it led us to a different result than what we found in this extremely large retrospective study. But my personal approach would be to apply the qSOFA criteria to patients in the emergency department. This is a prompt. This is something to tell you that a patient is about to get really sick, or maybe really sick already and you're just not seeing it yet. And I think since our first responsibility is to our patients, and since the best data that we have, the best approach that we have, the only one that has been validated using data in any way, state, or form, prospective, retrospective, or otherwise, is qSOFA or SOFA greater than or equal to 2. I think that it behooves us, if we are keeping our patients' best interest at heart, to use those diagnostic criteria. Now, that said, what you write down in the record, if you want to get paid, is something different altogether. Again, this is something that applies to the United States and doesn't apply to other countries. But our first responsibility always is to our patients. And if the best way that we know to identify a patient with suspected infection who has a high likelihood of a poor outcome is using qSOFA, then we ought to be using qSOFA.
I'm going to take the next one and then also get an opinion from Dr. Levy. The question is the Surviving Sepsis Campaign in 100% agreement with the Sepsis 3 definitions and criteria? Thank you for the preemptive laughter. So I will start by making the distinction for everybody that the task force was made up of 19 people chosen by the task force co-chairs, and it was endorsed by 32 organizations around the entire world, every continent except for Antarctica. People from critical care, people from emergency medicine, people from infectious disease, people from family practice. The Surviving Sepsis Campaign, and it was a single task force, the Surviving Sepsis Campaign, which is a joint FCCM, ESICM effort, has been in existence since the year 2000 or 2001, led by Dr. Levy, and that has been endorsed by 28 different societies, most the same, not entirely the same. Currently the number of people on the Surviving Sepsis Guidelines Committee, and there'll be another one coming out later on this year, is about 60. And I would say that if you asked all 60 people, do all 60 agree with everything that's in Sepsis 3? The answer is no. The vast majority do, and the vast majority come from organizations that endorsed Sepsis 3. But if you look very closely, there'll be one or two organizations that endorse Surviving Sepsis that did not endorse Sepsis 3, and vice versa. So high degree of Venn diagram, not 100%. Mitchell?
Yeah, I think that's all said. Craig, this is an interesting question because 100% agreement. I think once again, I always feel compelled to separate out what we're talking about here. The definitions, severe sepsis, sepsis and septic shock. I do think the campaign agrees with it, and I think you're going to see, I know you're going to see with the next iteration of Surviving Sepsis Campaign guidelines that we're going to change the terminology to sepsis and septic shock. It's a bit of an academic exercise because you just heard me tell you that, in fact, regardless of whether we agree or not, we have to use the old terms for proper coding. So we're a bit stuck in the middle, and we all knew that was going to happen. I think more important is this clinical criteria question. I keep trying to say this. I do not think, and I probably disagree here with Cliff a little bit, I do not agree and do not think that qSOFA should be used exclusively as screening criteria for sepsis right now. I think I'm aware of a few studies that already question whether we miss too many patients. I think it is more of a question of how much we believe big data, because that's what this is. This is a big data study. I think qSOFA is our best criteria for identifying a population that's likely to do worse. Would I use qSOFA today to screen for sepsis, and if you don't have 2 out of 3 qSOFA, would I just not keep looking? No, I'm not ready to do that, frankly. And so I think what you just heard from me and also from Cliff is there's no just one Surviving Sepsis Campaign body. I think everybody within that group, especially around clinical criteria, are going to have different opinions. But as far as the pure definitions go, yes, Surviving Sepsis Campaign is in 100% agreement with the change from sepsis, severe sepsis, and septic shock to sepsis and septic shock.
So that's a nice segue. More than one person has asked this question. I'll go first to Cliff. Under the new definitions, does SIRS still exist? And somebody else, will SIRS ever really go away? Do you feel that it is a good screening tool to help identify patients who are infected, or has it proven to be too nonspecific to actually be of any use whatsoever?
Okay, so first of all, at the risk of sounding like a broken record, SIRS is not part of the definition anymore, the definitions. It is not included in the clinical criteria that are used to identify the presumed infected patient who has likelihood of a poor outcome. That is, it is no longer part of the clinical criteria one would use to identify patients who would do poorly, who are likely to have organ dysfunctions caused by a dysregulated host response. That said, though, it's still something that ought to be measured. In fact, it's going to be measured. It's part of the routine workup of anybody who's sick. You're going to take their, you're going to take their heart rate, you're going to take their blood pressure, you're going to take their temperature, you're going to check their white count, et cetera, et cetera, et cetera. It is a reasonable identifier of inflammation. That inflammation may be caused by infection, it may be caused by injury, It may be caused by something else altogether. It does identify a change in physiology. Does it identify pathobiology, pathophysiology? I think the book is out on that, but my answer, generically speaking, would be no. I think perhaps what you see when you meet SIRS criteria is indication that there is a regulated host response ongoing as opposed to a dysregulated one. Clearly, SIRS will identify anybody with a bad cold. Those aren't the patients we're interested in here. SIRS will also identify the patients who meet qSOFA criteria to a very large extent. When Chris Seymour looked for overlap between the qSOFA group and the SIRS group, the overlap was fairly substantial. The problem, of course, was that SIRS identified a great number of patients who weren't in the qSOFA group. So that said, SIRS is useful in identifying patients with altered homeostasis. Whether or not it's an aberrant alteration in homeostasis, whether it represents dysregulation, whether it represents anything other than a presumably adaptive balanced host response to some perturbation or some potential threat to host well-being is unlikely. It's going to remain used. It's going to remain valuable. It's going to be something we use forever to identify infection, and it should be. So it's not going to go away, but it is now clearly less important or less beneficial in attempting to identify patients who are going to get sick. It has poorer predictive validity than qSOFA itself. Now again, that said, and I'll defer to Mitchell on this, we may be stuck with using it in terms of coding and billing because that's what the people paying the bills are looking for. And if we want to get paid, we have to give them what they're looking for.
Mitchell, I'm going to ask you a question from our ICU nurses. Statement says, ICU nurses here. What's a takeaway for nurses? Does this change when we notify MDs about concern for sepsis? It looks like qSOFAs for patients outside of the ICU. What should an ICU nurse do? Basically, do these new definitions change nurse practice at all?
Yeah, so this is essentially the same question that we're just talking about with SIRS. And I think you can see from just some of the responses you're getting from the three of us on this call, there's still an uncertainty. I remember qSOFA was developed in a data set of infected patients. So this data, qSOFA was developed after infection was already diagnosed. And that's why, fortunately or unfortunately, SIRS is not going away, which is why it doesn't change nursing practice all that much. And in fact, Jean-Louis Vincent and myself and Greg Martin just wrote an editorial for Critical Care sort of saying exactly this, that after all this time, and Jean-Louis, as many of us know, was the one who wrote Dear SIRS, We Don't Like You, in terms of identifying infection, and Cliff said this very well, until we have a good biomarker or a set of biomarkers that says that where a light goes on and it says this patient's infected or high probability of infected, until that time, we are stuck with SIRS. Not necessarily only the 4 criteria of SIRS, but a kind of whole host of signs and symptoms of inflammation that are associated with infection. And until we have a more precise way for diagnosing infection with rapid diagnostics, we're stuck with SIRS. And yes, it's very hypersensitive. And yes, we're going to identify a lot of patients, as we always have, who don't turn out to be septic. But for now, in terms of bedside screening for patients who are likely to be infected, we are still stuck with these signs and symptoms. Once we have a decision that someone is septic and we have evidence of organ dysfunction, we can use qSOFA to kind of predict who might get worse. But in terms of nursing functioning at the bedside and trying to screen for likely new infection, we are still going to be using SIRS, especially on the wards. We're about to have a manuscript come out of a trial that looked at using SIRS criteria for routine screening every shift by the nursing staff, whether on paper or electronically, that identified 1,800 patients that way with new severe sepsis at that time, now sepsis, who they were able to apply this 3-hour bundle to, and we had an associated decrease in mortality and in rate of ICU transfer. So my answer to that question is, for now, I would not change anything that we've been doing at the bedside if I was a nurse or if a physician for that matter. I think that we need further testing to make sure that we have, that this way of using qSOFA is going to adequately identify all the patients we need to identify for starting management and for improving survival, which we've been doing now for 12 years.
I'm going to
follow. If I may add, let's remember that qSOFA's best predictive validity is outside the ICU. An ICU nurse, you know, there is no advantage to using qSOFA over SOFA or anything else in the intensive care unit. So an ICU nurse should be doing exactly what they've always done, and we're all grateful that they've been doing it for so long. It's in the emergency department. It's out on the wards. It's in places where you don't have people with the clinical expertise to look at a patient and say, something ain't right here. I need to call somebody. I need to do something. Something more is going on here than just what we thought. That's where the value, I think, I hope, of qSOFA lies. In the ICU, the truth of the matter is that what we already have, in combination with the extraordinary skill sets of the practitioners working there, things seem to work pretty well.
So this segues off of what Mitchell was saying a couple of minutes ago about the difficulty in diagnosing infection. And somebody asked, why is there so much importance placed on infection versus no infection, since it's not always obvious, can't be identified for days if at all? So many reasons to have the same symptoms of organ failure, vent dependence, shock, etc. Why separate infectious from non-infectious sources of shock? I'll hand that to you, Cliff.
It's a completely pragmatic decision. I mean, the truth of the matter is that we all know, we all know that a large number of patients who are quote-unquote septic, a source of infection, a site of infection, an infectious organism is never identified. We know this for a fact. We've all seen it. There are studies documenting it going back decades. We specifically declined to attempt to provide criteria to identify infection. That's the purview of experts in infectious disease, experts in microbiology, expertise that we had represented on the task force, but that was not a common focus of the task force. I think we all recognize that organ dysfunction, that a number of the abnormalities that we associate with MODS, the multiple organ dysfunction syndrome, or what we're now calling chronic critical illness or sustained critical illness, that those are abnormalities that are not restricted to patients with known infection. I'd also point out too that, you know, the way these data were derived, the way that the studies by Shankar Hari and Seymour were conducted was using patients with suspected or presumed infection. That is, patients in whom somebody decided to start antibiotics and send off cultures in close proximity to each other for the first time. So a new presumption, a new concern that infection wasn't present. We never really looked to see how many of these ended up having positive cultures. My guess would be, and Chris Seymour would better be able to answer this, my guess would be that it's somewhere in the neighborhood of 50%, because that's sort of what you see when you're dealing with quote-unquote septic patients. In about half of them, you never identify a source of infection. Again, the charge has always been in examining sepsis to look at it as a process that is initiated by infection. That it could be, that the same process could be initiated by something else is possible, even probable, but not thoroughly explored.
The next one is just a comment that I'm going to read. Not a question, just FYI. I'm a medical director for a public insurance company. I pay bills, and I'm not at all wedded to the old SIRS criteria. So thank you to who sent that. A couple of people have sent questions about lactate. I will take the first one and then hand the second one off to somebody else. The first question is, if we have a patient with infection and on vasopressors, but with a lactate less than 2, can this new patient no longer can be considered to be in septic shock? And the answer to that is yes. Under the new definition, the patient is septic, they have life-threatening organ dysfunction, they have an infection, they do not have septic shock because their lactate is less than 2. The rationale for that decision, I believe, was in Dr. Deutschman's part of his talk, where the bottom line was there was a significant difference in mortality based upon whether somebody had an elevated lactate or not. If somebody was hypotensive and had a lactate greater than 2, their mortality was 42%. However, if they were hypotensive on pressors but their lactate was less than 2, their mortality was 30%. The understanding that's higher, so isolated hypotension is a higher mortality, isolated elevated lactate is higher, but both together was significantly higher. The task force, and the numbers are pointed in the paper because this was not unanimous, but the task force, ultimately the majority, decided that you needed to have both. So for purposes of the new definition, you need both pressors and elevated lactate greater than 2 to have a definition of septic shock. The next question I have, does anyone want to add anything to that?
Yeah, I would like to actually, because this is something that's come up a lot. And where it's come up in particular is with our colleagues in under-resourced environments where measuring a lactate is not something that can be done routinely and certainly can't be done quickly. You know, the new clinical criteria, and I say again, clinical criteria for septic shock put them in a very difficult position. One that we're sympathetic to, and one that mandates that all the clinical criteria we put forth need to be examined in that particular environment. However, think about it this way. The definition of septic shock says life-threatening organ dysfunction caused by a dysregulated host response to infection where cardiovascular, cellular, and metabolic abnormalities lead to a substantially higher mortality. Cardiovascular abnormalities are clearly present when you've got hypotension or vasopressor dependence. One could make the argument that some form of cellular or metabolic abnormality is present when lactate is elevated. However, that's not the only criteria by which one could evaluate the presence of cellular or metabolic abnormalities. Perhaps there's a perfusion deficit that one can observe clinically. Blanched fingertips, poor capillary refill, et cetera, et cetera. The advantage, the value of the clinical criteria that we put forth is that they're data-driven. This is what we had data available for. Now, someone ought to do a study where they say a combination of hypotension, vasopressor dependence, and poor capillary refill in the left hand is also associated with a poor mortality. And if those data prove to be true, then we've got a new criteria that's data-driven and validated as a potential index of metabolic or cellular abnormalities. That said, this is what we have. This is what the data tell us. More data, better answers.
Let's take another lactate question, and I have 2 of them that are fairly similar. The septic shock definition references lactate 2 or more. Is that an initial lactate prior to adequate fluids or a persistently elevated lactate after fluids? Another one says, Given all the new definitions require adequate fluid resuscitation before really taking lactate level into account, should I be encouraging my colleagues in the ED to wait to check lactate levels until they've hydrated the patients? I find them also called for elevated lactates and quote-unquote sepsis, which resolves with a liter or two of fluid. Those are from different people, by the way.
Yeah, I can take that. So the data set upon which the new definition of septic shock was based was the Surviving Sepsis Campaign database. And in that database, the lactate that was used was the initial lactate. That is that at the point of identification prior to administration of 30 cc's per kilogram, patient was given, lactate was obtained. So I would say that I would not wait until someone had received adequate fluid resuscitation. I would get the lactate first. However, the irony is you can't, the way the definition reads, it's after adequate fluid resuscitation, a patient is still hypotensive and on pressors. And so I would just encourage clinicians to just get a lactate. When you see a patient, just get a lactate.
Cliff, do you want to add anything to that?
I think that describes it very well. Look, we can't answer the question based on the data that we have available of what happens to what the value of lactate clearance might be, what the actual value of a lactate that's normal after fluid resuscitation is. We can say that the value in closest proximity to the identification or the suspicion of septic shock is the one that was used in the study. To get into the Surviving Sepsis database, it was supposed to be an initial lactate before fluid resuscitation was started. My guess would be that the clinical reality is that you see somebody who's really sick, looks like they're in shock, they get a bunch of fluid, and someone says, aha, better send off that lactate. Or it's done simultaneously. It's really hard to tell.
I think that's exactly right.
At some point, we're going to have to look and see what the value of lactate clearance is. It's an important measure. I mean, and Mitchell, you know, the person asking the question makes a really good point. I mean, there are patients who will come in with an elevated lactate, and as my co-chair Mervyn Singer would like to say, you give them a cup of tea and the lactate gets better, and so do they. Those are clearly not the patients we're talking about here. Those are also clearly not the patients who were identified in the data sets that we looked at on the basis, you know, on the basis of having poor clinical outcomes, prolonged ICU courses, death, etc. But the way things are set up now, we can't say anything more about lactate other than it's the first one that's on the chart.
We have 10 minutes to go, so I'm going to ask you guys to keep your answers relatively short so we can get through as many questions as possible. But I just got a real-time answer to when you guys were speaking. That's very interesting because I was understanding the new septic shock definition to be persistently elevated lactate and vasopressin dependence after adequate fluid resuscitation. Is it before or is it after? Not saying should you check a lactate, but in the definitions, is it before or is it after?
I have to go back and actually look. I honestly, I don't want to give out misinformation, so I do really have to look at the manuscript. I think the point is, it's identifying really sick patients. And so I think what Cliff said is really true. People often come to the emergency department and you get a lactate. My understanding and honestly my opinion is that it's a lactate greater than 2 in a patient who's hypotensive when they come into the emergency department is a patient who's being identified as septic shock. If they are hypotensive and they remain hypotensive after fluid resuscitation and their lactate was greater than 2 on admission and they're on vasopressors, that patient's in septic shock.
We're going to go bang, bang through a couple of questions. If a patient is seen in the emergency department and qSOFA is positive, do we immediately start using SOFA right afterwards?
You can if you can. You should if you can. I think part of the point of using qSOFA is a prompt to fill in the blanks in SOFA and perhaps to escalate care, to be more suspicious, to get the patient to a place, if possible, if such a place exists, where the intensity of care is higher, like an intensive care unit. I think that's probably exactly probably the best possible way to use qSOFA, is to tell you to be suspicious, to tell you to get additional information.
Yeah, there's one figure in the paper, and that's exactly if you screen positive for qSOFA, you should look at the SOFA score if you have the ability to calculate it. Next question, why SOFA and not Apache 2? With the prominence of smartphones, any of these calculations are easily done through an app.
Well, Apache 2 is a severity score. SOFA identifies organ dysfunction. Two very, very different concepts here. I think that's very important. We're using SOFA score not to predict how sick someone is. We're using SOFA score to identify organ dysfunction. And that's really important. We changed the definition of organ dysfunction from the second consensus conference. The definition now is a rise of two more points in SOFA. Apache 2 is a severity predictor. You could ask why qSOFA rather than Apache 2, and the answer to that is Apache 2 is a very old system. The only value of Apache 2 is the case match for clinical trials. No one would ever use Apache 2 for anything other than that.
I don't know that Apache 2 has predictive validity. Apache 2 will identify sick patients, will tell you how sick somebody is. It won't tell you anything at all about outcome. I don't think Apache 3 will, but Apache 2 I don't think did.
It's helpful for populations. It's not helpful for individual patients. The next question, is there an alternative or suggestion for qSOFA point of systolic blood pressure of less than 100 for individuals whose baseline blood pressure is always less than 100? Are we looking at a % change from baseline blood pressure or an absolute number?
That's a question we can't answer.
Right. Well, by purely qSOFA, if your baseline blood pressure is less than 100, you cannot use that element. So you're looking for one of the other two elements. And that is the problem with qSOFA. The same thing if people come in with a baseline altered mental status, you cannot use altered mental status as one of the elements, so you're left with hypotension and a higher respiratory rate. If someone comes in, for instance, a chronic renal failure patient is dialysis dependent, or a cardiomyopathy patient, and their baseline blood pressure is in the 90s, and at baseline they're demented in a way that you can't tell a change in mental status, you cannot use qSOFA.
The same thing is true of SOFA. We say it's 2 or more SOFA points. We're not talking at all about what the baseline is. The presumption is that the baseline in most patients is 0. But there will be patients in whom that's not true.
Has STO2 been considered to identify the really, really sick patient earlier?
STO2, you mean looking at tissue oxygenation?
That is what the question says.
Yeah, so that's I think one of the, it's specific to some of the vendors, and that has not been used in any of the calculations in the definitions conference in the task force.
Am I correct in understanding you to say that SOFA and the new shock definitions are the best predictors of extended ICU care?
They're the best predictors of an ICU course of 2 days or more that we examine.
I'll take this one. It seems like qSOFA is a non-specific criteria that could be met by a plethora of patients. Do you recommend any other indicator to narrow down the patient population? It's interesting because most people, the criticism for qSOFA is that we're waiting too long until patients are too sick, rather than it's too non-specific. And what the general statement is if you have somebody who you're concerned about infection, look to see whether they have qSOFA, look to see whether they have SOFA. If you have somebody who screens positive for qSOFA, but you weren't suspecting infection, look to see perhaps if they are infected. So it's a prompt to somebody you think is infected to look for sepsis, and it's a prompt to somebody who screens positive to look for infection. Cliff, do you want to add anything to that?
If you think that qSOFA is going to be too non-specific, it's a prompt to fill in the SOFA. Measure more stuff and see if your SOFA comes back positive, because that had a better predictive value than qSOFA did. It's just more difficult to use.
one of our listeners has actually gone to our paper, to our lactate conversation, and says the paper from JAMA for Sepsis 3 reads, and I quote, vasopressor requirement in serum lactate greater than 2 in the absence of hypovolemia. To me, that reads as persistently elevated lactate after resuscitation. I find a persistent lactate elevation to be more severe to me than just an initially elevated lactate. I would agree with that. Others?
Agreed.
So,
We wrote it, so we agreed.
we voted on it, and we didn't agree, so it was a majority rule. Yeah, I mean, look, this has, makes sense. Let's put it that way. That lactate that doesn't get better indicates somebody who's sicker than lactate that does get better. But again, the data, we just couldn't do that particular analysis.
Here's somebody who is concerned that there's too much overlap and too few criteria, such as lactate and pressors, that it overlaps with cardiogenic shock, septic shock, hypovolemic shock. What's the use?
What's the use of, I'm not quite picking that up. I mean, there's no overlap if you have a documented or suspected source of infection. On the other hand, those of us who practice at the bedside on a regular basis are often confronted with, is this septic shock or is this cardiogenic shock or a little bit of both? So let's not kid ourselves. This definition is not going to solve the problem of to what extent is the shock we see from the pneumonia the patient has, and to what extent is it from the fact that their baseline ejection fraction is 20%. We deal with that all the time. That's not going to be changed by a definition.
And this is a different group of patients. Maybe you could answer the question if you had included in this analysis a whole group of patients who were known to have cardiogenic shock and weren't suspected of having infection. Maybe qSOFA does work just as well in those patients. We don't know because those aren't patients we examined.
And the final question, and we have a couple of minutes to go and we'll finish up, is this, I'll take the first version of this, is the society trying to create a definition of sepsis to improve patient care or for insurance companies? And I will say unequivocally, we did this in a patient-centric fashion with the goal of being to improve patient care today, to better intellectually understand the issue, and also to set up ideas about what we need to do better and understand better for the patient in the future. Mitchell or Cliff?
Yeah, I would love to add to that. I mean, hopefully what's come across in this conversation is, in fact, if we've done anything with the new definitions, we've made the insurance companies more miserable. And it's a testament. It's a testament to how much we've ignored both third-party payers, whether it's insurance companies or government, right? What we've done with these new definitions essentially is said, hey, wait a minute. When you think someone's getting sicker, you say, watch out, this patient's getting septic. You do not say, watch out, this patient is getting severely septic. This was all in the interest of improving communication and precision in the way we manage patients with sepsis. It has nothing to do with insurance companies.
And to be perfectly practical about it, keep in mind, number one, the FCCM has a large contingent of members, a large membership outside the United States, so that all these reimbursement issues don't apply. And half the task force were not Americans. In fact, more than half the task force were not U.S. citizens or practicing in the United States. And their input counted every bit as much as the rest of us. So clearly, this was being driven by people whose focus was on care of these septic patients, not on reimbursement for the septic patient.
And on that, we can all agree. I'd like to thank very much Drs. Deutschman and Levy for your efforts in preparing for and delivering this outstanding webcast. And thank you to our audience for participation. To access the recording and slides for today's webcast, along with other sepsis definition resources, please visit www.fccm.org/sepsis redefined. This concludes today's webinar. Thank you very much.